morning, good afternoon, good evening, whatever it is, and whatever time you're listening. Welcome back to the next episode of the Dental Implant Podcast. I'm sounding not quite myself at the moment because I've got this weird head cold thing that's been going around. It's just so my sinuses are a little bit blocked, so I apologize. I apologize for that. And I am very happy to be here with a friend of mine, somebody that I've known for the best part of about 14 years. Sunil Hirani is a specialist orthodontist, and to say that he's a specialist orthodontist is to do him a little bit of a disservice, actually, because he was a very high-level consultant doing all sorts of crazy cases with ortho. And this podcast just kind of like wanted to be recorded. It was almost off the cuff, wasn't it, Sunil? Because it was just kind of like, because you're actually, see, this is the dedication of this man, right? He's abroad on holiday with his family, and he's like, Pav, I can carve out half an hour, 45 minutes for this. So he's actually in Dubai at the moment, making me very, very jealous. And he's very kindly offered to spend a little bit of time with us to go over the interplay between orthodontics and implants. So Sunil, thank you so much, and I hope I'm not in too much trouble with your family for dragging you away.
No way, man. Listen, I never say no to you, and anytime you need me, all you do is press the button. That's what friendship is about. I owe you a debt of gratitude as well. Firstly, thank you for having me on this podcast. And secondly, I've learned, things from you that have shaped my clinical career and my clinic. And in fact, as you say, we met over a decade ago. I think you were at Guy's as well. I think you're a Guy's man.
Yes.
Yeah. So correct. I think you were a couple of years behind me in the program. So now we're going back to about 20 years, if not more.
Yes.
Right. And you ain't changed a bit. So, it's a great pleasure to be here. I hope I can answer some of the questions tonight. I'm going to bring you up to speed with some of the even more crazy stuff I'm doing. But fire away, please.
Okay, so Sunil, can you just give those listening just a little bit of introduction to yourself, a little bit of a background, so kind of like the listeners know who they're talking to, so they understand that when you're talking from a point of knowledge and experience?
Yeah, sure. Okay, so my name's Sunil Hirani. I'm a specialist orthodontist. I have been for almost 20 years. In fact, in 6 months, it will be my 20th anniversary that I've been on the register. And basically, yes, I've done all my basic training, undergrad at Guy's, blah, blah, blah. Worked in hospital, in various hospitals, senior house officer posts. I then did my fellowship in dental surgery. That exam doesn't exist anymore. It's been changed a number of times. But that exam had a ruthless pass rate when I did it. It was between 20 and 25% that ever made that exam. So the rest of those people were thrown out. And if you didn't get that exam, you couldn't apply for orthodontic training. So that's the cutthroat level it was, when I passed it in 1998. And the funny thing was, it was a Royal College of Surgeons exam. I won't forget this story because I qualified in 96. When did you qualify? Was it 98 or
2002? Actually,
2002. Okay. So I qualified in 96, and then I was determined to become an orthodontist because people said it can't be done. And whenever someone says something like that to me, it's like a rocket that's been inserted into me. It just sets me off. Yeah, because I don't like hearing the word no, and I don't like hearing the word it can't be done. Anything impossible. If your mind can conceive it, then you can achieve it. It's as simple as that. And it's the same truth in implants as well. Am I right?
100%.
Yeah. So if you can see it in your mind, I know you're going to make it happen, or you're going to try your best. So then what happened was basically I then had to do various jobs. Of course, the killer part is, passing this, ruthless exam. And I got the part one, again, 20-25% failure pass rate. I got that first go. And then I did the part two. And the part two, again, is the same statistics. And I got that as well on my first go. And then I get a letter from the Royal College of Surgeons at Lincoln's Inn Fields in London, Holborn, saying, dear Mr. Hirani, well done on passing your exam, but we cannot give you this award yet. And I looked at this letter in absolute disbelief, Pav, saying, listen, I've done everything. When a man, does everything he's supposed to, he should be paid his dues. Yeah. When he jumps through all the hoops and everything in life and he makes the sacrifice, he should be rewarded. And then I read the next bit of the letter, and the reason is it says you have not been qualified for 3 years, and the rules of the examination are you need to be qualified for 3 years minimum. So in your case, you've sat the examination at 2 years and 5 months after qualifying. If you're prepared to wait for 7 months, we will give you this award, because I sat it in record time. And of course, I'm happy to sit back and chill for 7 months. I've got other things to do, but make sure, you honor this. So that was my first step, that exam. And I won't forget that exam ever. That was the hardest exam I ever did in my life. And Pav, how things are today in 2022, soon to be 2023, the world has changed so much where you can't behave in a certain way. If you did things like that today, you'd be accused of bullying. For example, in that examination, what they said was in the hallway foyer of that college, what it says is, when we announce your candidate number, please step forward. In other words, Pav, if they don't announce your candidate number, you didn't make it.
Yeah.
And in front of everybody, they just... And so, there must be 100 of us in that room minimum, and the first number is 11. So you look around the room, you can identify 10 people and some who are already in tears. So this is no joke, because we've got people there who have come from the Asian subcontinent, from the African subcontinent, just to get this exam so they can progress in their careers. And when I spoke to these people, I said, listen, you're not allowed to work unless you have this exam. How are you getting by? Oh, we work at McDonald's. We hustle there. We work at KFC. I work as a postal worker. And I'm thinking, okay, this is just heartbreaking hearing these stories. And these people are sitting outside the building crying because obviously they've had to fly over. They're staying in some low-level bedsit. They're doing these jobs to survive, and then it doesn't work out yet. Maybe they get it on their second or third attempt. So that was the first hurdle I got through. And then from there, moved forwards and then got into the orthodontic program at Guy's and Canterbury hospitals. I was working between two and, traveling back and forth for 3 years. I did my membership in orthodontics examination and I was informed by the head of department I passed comfortably. I didn't win the gold medal, but I passed comfortably. And then basically I thought, you know what? This isn't enough for me. I'm ambitious. I love learning. I'm very self-critical. And I think in our games, Pav, for you to push yourself, the harshest critic is you. It's not me. It's you. Yeah. It's you that has to prove something to you, right? And if you're not 100%. Happy with your work, there's nothing I can say about it to make you feel good. You're not happy. What you're going to be thinking is, how do I improve this next time? And how do I raise my game? It's an internal thing, right? And that's, some kind of pride we have, yeah? That's some kind of self-pride. You can't teach that. You don't learn it in a university. You can't read it in a book. That's something you have inside of you to be even better, today. So in other words, you can never stand still. If you're standing still, because I'm a big boxing fan, yeah? Vitaly Klitschko says you're actually moving backwards. If you're standing, because time keeps moving forwards, okay, a year later, you have actually moved backwards because everyone's come forwards a bit. So you can never stop. And even if you move just an inch a year, you're still progressing.
Yeah.
So I truly have that mindset. So as soon as I got my MOrth, I thought, right, this ain't enough. I need to do more. Next level, okay, consultant training. That's another 2.5 years of my life. And obviously your salary isn't what it could be compared to your colleagues who are out in practice. So that's the other sacrifice you're making. And then I worked at Guy's and Bournemouth, again, traveled between the two, long commutes. And then I sat my consultant exam. And there were about 12 of us. We had to fly up to Scotland to do the exams for a couple of days. And lo and behold, out of 12 of us, I got effectively the gold medal. I was first in the country.
Nice.
And it was a nice feeling, yeah, when you're sitting in front of these examiners. Because I don't know about your original background before, guys, but I grew up in poverty basically, so I'm really just a street guy. I'm not someone, who ever went to a prep school or a boarding school. There was no silver spoon. In our family, it was a wooden spoon, yeah, one wooden spoon that everyone uses to eat. You cook with that, you eat with that. That's how we grew up. So we were, kind of street people, really. And it was a nice feeling when you're sitting in front of these examiners, Pav, and they're just firing questions at you, and you're firing them back, and they've got nothing left to say to you. It was like a tennis match. You rattled it off. And with the acronyms I'd learned, there was stuff that had just come out a few days before, and they didn't even know about it. And and they're firing acronyms. I'm thinking, hang on, pal, you got the acronyms the wrong way around. But I'm not going to correct you in an exam. I'm going to let it go, but don't make that mistake again. Yeah, but so basically, yeah. Then afterwards, the exam, they just said, yeah, look, there were 3 sections: clinical, management, and research. And you got the maximum marks you can get is an 8. The lowest is a 3. You need a 6 to pass. You need 3 6s, and you cannot compensate. You need 3 6s all the way. And they go, you got 2 8s and a 7. So they go, basically, you've dropped 1 mark in the whole exam.
Yeah.
And I dropped the 1 mark, and I thought even that was harsh, because I thought, come on, guys, give me a break. I thought, I've just shown you a class 3 malocclusion with hypodontia. She's missing a lateral incisor. The other lateral incisor is peg-shaped. She's got a reverse overjet. She's got a facial asymmetry, so the midlines are off. And I've treated that in 2.5 years with the orthodontics. The surgery was done, and the bridge was fitted for the lateral incisor, and the peg lateral was built up with composite. And they go, yeah, but your millimeter's out, your midline's out by 1 millimeter. And I said, come on, guys, give me a break here. I mean, she's, from where she started to where she's ended up. But obviously, they've got to find something, right? I mean, that's the name of the game.
Yeah.
But either way, I mean, as soon as that happened, then they're all offering me jobs in their hospital departments. And then, from there, I'd already published, I'd presented at conferences. I was always a bit odd in saying, right, I make things personal, because when you make something personal, Pav, like, for example, before I joined you on this podcast today, I did a little Google on you. Yeah. I did a little Google on you. Yeah. And I still see you looking as handsome as ever on the internet with your picture and everything. And it's got your background there. But the one thing I really like that stood out of my mind, it says, placing implants is a personal decision for me, because this is what my grandfather said to me. And I thought, wow, a statement like that from a close family member actually changed your life. It actually changed your course of destiny.
That's why I'm so passionate about teaching as well, because it's part of the same promise. It's so that's why I love to teach. That's why I love doing this. That's why, like you live and breathe orthodontics, I live and breathe implants as well. I just can't get enough of it. So yeah, I think for those listening in at the moment, I think you get the idea that Sunil knows what he's talking about.
Well,
so what we're going to do.
This is 2 heavyweights here tonight having a slugfest. This is Joe Frazier and Muhammad Ali. This is another, thriller in Manila. We've got 2 guys that have, because I've got a lot of, love and respect for you. And you are the real deal, and you are a heavyweight, because a guy who is, if I use the word, if I'm out of order, tell me, but a guy who's more or less obsessed with dental implants, I have to take my hat off to, because that's a sacrifice. You could have dropped out at any stage. You could have decided to become a generalist and do a bit of everything, but you made a decision and said, no, I'm going to focus on one area, and I'm going to follow this through. And also, like your bio that I read tonight on Google, you're a movie fan just like me. But I love the action movies. Yeah, so I'm a Netflix fan like you. I could watch Netflix. In fact, after this, I'm watching Netflix because there's a Denzel Washington movie I want to see. He's one of my favorite actors.
Which one is it?
It's an old one. I haven't seen it before. It's called John Q.
Okay, yeah. It's a good film.
Yeah, I haven't seen it yet, so I'm about to find out later. But I just lost a video there, but I can hear you.
Yeah, it's just because your internet's a little bit weak, so it cuts your video off, but it'll keep recording the audio, so there's nothing to worry about.
Yeah, no worries.
Yeah.
You think the Hilton could do better, don't you?
Yeah. So Sonia, I've got some questions now for you. Okay.
Yeah, go for
it. So orthodontics and dental implants, I think they're separated quite a lot. And I have a theory as to why, because they're both relatively expensive treatments. So when you combine them, the cost for the patient goes up more. That said, there are a lot of cases where I am wanting to help a patient. Patients come in to see me, they either need a teeth removed or they've got a handful of teeth missing already, and they want implants putting in. I'm looking at it going, I physically can't do this because I haven't got the space. Or the other thing that I get is I sometimes get colleagues who send me PAs, Pav, how am I supposed to restore this? And my response to it is really, really easy. I said, look, the implant's in a great place, phenomenal place. You just don't have enough space. Send it to an orthodontist, get them to open it up. You know, a lot of this should have been diagnosed beforehand, before the implant went in place. And in my earlier days, I had a lot of cases where I put the implant and then I couldn't get the restoration on because I hadn't assessed it properly. Or you end up putting the implant in, putting a restoration on, but the patient's having a massive food trap because adjacent teeth have tilted in. And we see it all the time. You know, lower six has been missing, 4 or 5 years goes down the line, seven's tilted forward, and all of a sudden the patient wants an implant. Sometimes if it's only a little bit of drift, you can just flatten off that contact with a high speed. But other times we need to have orthodontics. And I think, so the questions I have for you is firstly, where do you feel that orthodontics really comes into its own strength in optimizing implant therapy? And in addition to that, is another big aspect which is grossly underappreciated and underutilized is what we term ortho-osteogenesis, where you move a tooth through a position to generate bone. So, you know, I think that a lot of the listeners would be appreciative if you could give us your thoughts with regards to that.
Yeah. So the first question. The role of orthodontics, really. So it's one that, as you say, you appreciate with time and experience. And it's interesting that when you lose a tooth, you get these side effects, Pav. You know, you get drifting of teeth, tilting, you get rolling of teeth as well, you get space loss. So before any kind of treatment is actually performed, I obviously believe in a thorough diagnosis. That patient ideally has to be, disease-free. Any perio should be stabilized as much as possible. Any caries should be stabilized, and the full examinations, including the radiographs and other diagnostics, have all been done. And then from there, my other philosophy is that all treatment plans, and I learned this from Frank Spear, the guru in America, that all treatment plans are restoratively driven. So that means even me, I'm not the main player. I assist in trying to achieve the goals of treatment, because obviously the goals of treatment are to achieve good aesthetics and good function. Yeah, you always aim for those things. And they're the two branches of dentistry. Regardless of what you're in, you're always trying to get those goals. So I would say to someone who's starting out in the field of implant dentistry, don't just think implants, just think, try and think 20 years ahead. If this patient ever wants ortho after the implants are put in, it could be really difficult. And I've had that happen to me as well, where, the patient now says, right, okay, fix it. And I'm thinking, well, I can't, because you've got multiple implants everywhere. I can't move teeth here and there. I don't have the space. Yeah, and we're not going to do something crazy like remove the implants and trephine them out and deal with the consequences from there. So wherever possible, if you're trying to get a beautiful result, yes, you would need dental implants to restore function and aesthetics if you're missing teeth, if it's clinically possible. But you also want the arches to be well aligned. You want a good overjet, a good overbite, because the other problem I found in dentistry as well is deep overbites are horrendous. They damage your good work. Yeah, when you've got these horrendous, powerful masseters, and you've got these deep overbites where the incisors have over erupted, smashing up on your newly restored teeth, they just cause havoc. And again, it was one of Frank Spear's colleagues, another chap in the States, Gary DeWood, who's with the Spear Academy. He goes, look, we always like, light contact on the teeth. Anteriorly, we like light contact. We don't want heavy contacts. So again, that's where I think orthodontics is wonderful. It can help intrude teeth that are over erupted, for example, a deep overbite. It can upright teeth, especially when you want to put implant fixtures in. When you have these tilted teeth, as you say, you can remove a little bit of enamel. You can do some enamel plasty, but there are limits, Pav. You can't just keep going like that, and again, it might become a compromise. That could insert, the angle that you place your fixture. It could make the restorative treatment more difficult, when you've got to do the implant-supported crown. So I think ortho is a great nugget. With the implantologists I've worked with, what they've said is, although your work takes the longest, it takes years, and ours is less time compared to you, you make us look good. Yeah, because basically you're the defender or the midfielder. You're not the striker. We're the strikers. And they always tell me that, the implant guys always say, we're the strikers, don't forget it, the patients love us more because when we give them these teeth, they're just over the moon, They've forgotten about you. You did your bit, you got paid, and you gone. Yeah, and I'm thinking, all right, man, thanks, I know my place. But I think if you get the best out of all these, different areas, I think I've always believed you get synergistic effect. You truly get, the sum of the whole is more than all of the singular parts. It happens every time.
Yeah. So one thing I wanted to go back to, which is something that you said earlier as well, is these deep overbite cases, because these cases trip you up really, really quickly as an implant surgeon. So with these cases, you quite often get it's the upper central or upper lateral, which is sheared off at gum level, and you're looking at it and you're going, you know what, this is a slam dunk case, but you're not looking at the opposing arch because you haven't got the space there to restore everything. You're looking at it and going, perio's pretty good. There's plenty of bone in there. We're going to do socket shield or whatever it is we're going to do. We're going to do an immediate placement, and it all goes absolutely beautifully. Is you take your PA implants in a perfect position, and it comes to restore, and there's just no space for your restorative material at all. And I've been tripped up by this when I was younger, and what ended up happening was you end up having to make big compromises in that you end up having to make an all-metal palatal surface because that's the only material that you can kind of get down thin enough. Or the other thing that that ends up happening is even though you've got an all-metal palatal surface, the screw access is so short you can't cover it properly. So can you go into these deep overbite cases, kind of like what we should be looking out for? In addition to what we should be looking out for is if we refer out to an orthodontist, what we should be asking them to do. And as an orthodontist, is there a quick fix to this, or is it just, comprehensive ortho, that's the only option?
Yeah, so, I see deep overbites every day. And of course, I see them in children, because as you know, I treat a wide age range. And even in children, classic signs are early signs of, tooth wear. You see it, with the chipped lower incisors. You see the palatal wear of the upper incisors. You see some soft tissue loss. So early obvious signs. But for me, what is gospel is that most patients within Europe have a class 2 malocclusion, more prevalent than class 1, more prevalent than class 3 PAV in Europe.
Yeah.
And most of those class 2 patients will either have an increased overjet or an increased overbite. So I'm expecting to find it every time I look in someone's mouth. So I would say if you can level the lower arch, i.e. it's what we call the curve of Spee. Curve of Spee. If you can level that as much as possible, which means you need lower incisor intrusion and you need premolar and molar extrusion, you get a flat line, or you flatten that curve. And that is the basis of your orthodontics, because you've now aligned one arch. If you can align the other arch and you can get a good occlusion, because that's the other thing orthodontists sometimes, they don't think about. It's not about, as I'm sure I heard, Tipton say it as well, I think he said it on Facebook, he gets tired with orthodontists that give him lovely static occlusion, looks great in photos, everything's touching, but he's not interested in that. He's interested in the dynamic occlusion, what's happening in real life, yeah. And so I think if you can look for the signs and expect that overbite needs to be resolved. Now your question was, can it be done quickly? The answer is no. Aligners can't do it quickly. A fixed appliance can't do it quickly. Out of all 3 methods of a labial fixed appliance, a lingual fixed appliance, and clear aligners, generally there's only 3 types in the marketplace. The lingual appliance works the fastest because the brackets are lingual, the archwise lingual, and the force is going directly through the center of resistance of the lower incisor. So if you imagine that, this is my lower incisor, the force is going almost directly through. So you get almost pure intrusion. And it happens within 3 to 6 months. I'm impressed in an adult where you've got these horrendous overbites that with a lingual appliance, you can do it like that. With a labial appliance, it takes far longer because the teeth are not intruded vertically. They're also proclined. And sometimes you don't want that. Well, if they're, missing some soft tissue here, do you want more recession? So that you got to be careful with. And aligners is very hard because deep bite correct, it can be done, but you need to go through many aligners. Yeah. It's what we call refinements. The first batch, didn't give you everything. So you got to go through round 2, sometimes round 3. Then it gets a bit frustrating for the patient because they're saying, this is going on and on and on, and I'm changing these aligners, so it gets quite hard. Yeah. So I think overbite correction is, key to restorative success. So you make the space that way. You intrude.
Yeah, 100%. I agree with that. And I've got some patients where I've turned around and said to them, look, without orthodontics, I cannot do your treatment for you. And I've had other cases, particularly, like I said, if the patient's got a premolar missing and the molars are tipped in a little bit and you just haven't got, I turn around and say to the patients that, look, go to see an orthodontist, right? And either get them to open up a space, or the other thing speak to your orthodontist where instead of opening up, they can just close it all down. I said, yes, correct. Cosmetically, a little bit of a compromise. I said, but it might actually be the best thing. I said, that's a conversation you need to have with the orthodontist. So sometimes as an implant surgeon, you've got to think, well, not only as an implant surgeon, mate, is whatever we do, it has to be restoratively driven. And even though we don't operate I don't operate as an orthodontist, you don't operate as an implant surgeon, it still means that I need to understand the basics of what can be done with orthodontics in relation to implants, right? You need to know. Yeah, you need to know how orthodontics fits into implants. That's how we look after our patients the best. So, sorry, folks, the answer to reducing a deep bite quickly is no. But we've also heard that it can be done quicker with a lingual appliance. So, for those patients who want kind of like a quicker result, that's something I can say to them that, look, you can do this faster with a lingual appliance. So you're going to need to see a specialist. And, if that's what the patient wants, then that's what the patient wants. I can't stress enough that there's a difference between I can do this and it's going to be tricky versus I'm not prepared to do this. Okay. If it's, I can do this but it's going to be tricky, that's a conversation you can have with the patient. Right. But if it's like 100% deep, 100% overbite and you haven't got any space at all, a completely different conversation you've got to have with the patient. Then the conversation is, I physically can't do anything unless this is done.
Completely agree. And as you say, it always comes down to managing the patient's expectations. I don't know about you, mate, but for the last 20 years, I've witnessed those expectations creep up and up and up. And our game is not like Amazon Prime. Yeah. We can't make, next day delivery, nor can we serve you a McDonald's meal where we've cooked that food in bulk and it will be ready to, dish out any minute now. We don't work like that. Your game is not like that either. We're dealing with, the patient's biology, and you're dealing with, people and their anxieties, and, whether it's clinical or, whether it's financial or whatever. So, this is not an easy field, for you and I to be involved with. And we have to be honest as well. I've got patients that it's funny, Pav, because after all these years, I'm actually saying no to more and more patients. And sometimes it's not because I can't do it clinically. I can do a fair amount clinically. I've got a tremendous amount of self-belief in my abilities because I've traveled all over the world like you, seeking out the best people. But sometimes I think to myself, I'm not going to get on well with this patient. If you and I can't be friends with a patient, there's no point starting, Pav, because it don't work.
I completely agree. And this is something that when we first met, this is something that older colleagues would, because I was young back then, is
you still are, man.
This is what a lot of older colleagues were saying to me. It's like, don't be bullied into treatment, and don't do treatment just because you need the money. But the flip side of that is I think that's easier said when you don't have the money pressures. So when you've got the money pressures, it's also different as well, right? But I also agree. I get a lot of patients where, and it's just a personality conflict. It may be that, I'm not the easiest of people to get on with, right? But I'm damn passionate about what I do. And there are certain personality types that don't get on with me, and that's fine. And sometimes I turn around and say to the patient, I don't think I'm the right person to help you. Here, let me give you somebody else's number. Knowing that this other person is going to be a good personality match for them. And
I think you're right.
It's really, really important.
Yeah, but I mean, I didn't have that ability over a decade ago because I was too eager to please everybody. And really what it is for who you are and the skill sets you have, you fit with a certain percentage of the population. You won't get 100%. You can't be everyone's personality type. Yeah. You'll click with a certain percentage. There'll equally be a group of people out there, no matter how passionate you are, how good you are, they will think you're the world's worst dentist. No matter what you do for them, you will not hit that level of satisfaction. And if you can't do it, the chances, I bet, Pav, no one else can do it. That's what my money's on. It's not you. It's them, and I bet you, because these people are full of secrets, you're not the first clinician they've seen either. They've got a whole folder where they've been here, and here, and you can spot it in their body language. And some of them are open and say, you're the 10th person. Some of them won't say anything, but they're just highly, highly knowledgeable, which is just unusual. Yeah. And you're thinking, okay, fine, listen, I'm going to be honest with you. I don't think I'm the right guy for you, and it's really important you find someone that you can gel with, because this treatment goes on for a number of years. And so I learned this. I mean, the thing is, I learned this the hard way, like you. I took on people I shouldn't have treated, and it was messy at the end. Although fantastic clinical results, the patient was just an absolute nightmare. They were unpleasant, and and they make all sorts of threats, and that that's fine. I mean, that's why we have indemnity. But we don't need those hassles. But then what I learned from a prosthodontist was, look, let it go. If you spot the red flags early on, and, ideally at the beginning if you can, not when you treat them and it's too late, obviously give your reason why you don't believe you're the best person for them. And as soon as they walk out the door, I guarantee you the next new patient's coming in and you'll have forgotten about them.
Absolutely. So here's something that I say to patients a lot when I feel that they're being unreasonable, and then based upon their It normally works for me, and again, this works for my personality type, just because of the way that I am. When a patient's like, "Oh, when you're speaking to patients, you're talking about pros and cons of implants. You say, "Oh, there's a 1% risk that the implant's going to be rejected. There's this risk, there's that risk." When they turn around and say, "No, I need everything finished within 2 weeks because I've got to be somewhere. I'm not prepared to take any risk because, I'm not prepared to take any risk of the implant failing. I'm not prepared or just when they're being unreasonable, I just turn around and say to them, I say, look, I'm damn good at what I do, but I'm not a genie. I can't grant these wishes to you.
No.
If you want me to, if you want me to do it, I promise you, I will do my very best that I can for you. This is what will probably happen. But if you're expecting no hiccups whatsoever, I said, I'm not the right person for you. And most people go, oh, no, I was just, quite often they're just blowing steam because quite often they're nervous. They just want a little bit of reassurance.
Yeah. I mean, I think some are nervous, and I also think some are not of a sound mind. I think, we have got those patients out there who are obsessive compulsive disorder or body dysmorphic disorder. I've had those patients.
Yeah.
And effectively, I cannot spend all my time managing just a few of those patients in my clinic when I've got so many other patients to equally look after and care for. And
Absolutely.
so I've made the decision with my team saying, right, if we get any unusual phone calls or things are just not right, we may not follow up that lead because really, it's not going to work well in our favor. Yeah, we have to, work with these people like they've got to work with us. It's a two-way relationship. And as you say, if it's not going to work, cut your losses early on. If you have to refund a small, if you have to refund the small consult fee in relation to the overall cost of treatment, do it. And just think, fine, okay, I learned something there. I met one person. That was a near miss. Good thing we didn't go any further.
Absolutely.
And it's taken me all these years, Pav, just to realize that. Before, I'd look at it as a failure. I'd look at it like, well, I let that one get away and it was worth, so much, revenue and all this stuff. And I'm thinking, no. Look, as long as you make enough and you're covering all overheads and you've covered yourself, that's fine. So, okay. So the second part of your question, when there isn't enough bone, what do you do? Okay, fine. Well, I'm not going to tell you about surgical augmentation because you could talk all day on that. But the other alternative is orthodontic augmentation. Now, if you can close the space, fine. And I've done that before where a couple of my implant friends have said, oi, you've just diddled me out of an implant here. The plan was you do the orthodontics and I'm going to put in 3 implants. That was the goal. It looks like now you've closed 2 of the spaces and you've left me 1 implant. And I said, okay, sometimes if the patients have less dentistry, the better, right? There's less to look after. There's less to go wrong. And if I can do it orthodontically, I'll try and close the space if the patient agrees and they consent. But the other thing, that I've been doing for years is the orthodontic ridge augmentation technique, where supposing, I don't know, a patient's missing a lower lateral incisor, it was traumatized, it was knocked out. And after 20 years, basically, you've got severe atrophy. There is no proper cortex, you've lost that. You're not going to get a fixture in there easily. So what some dentists have said is, right, well, can you get the central and move it to the canine? So you put it in the lateral that's been knocked out and you leave the central space open for me and I'll restore that. And I've done that and they've got a beautiful fat ridge. They absolutely love that, to get their fixture in. And I've done that in the lower arch. I've done it for in the premolar region in both arches. I've done it, when you're missing upper laterals, you move the central and canine, you move it back again. But for those patients, Pav, they need to be well informed. Yeah, they must be able to consent to this, saying, okay, you're going to spend a very long time doing this treatment where overall I should get a better result and I don't want a bone graft, but you say you can orthodontically move the teeth and that should eliminate or reduce the need for a bone graft. Yeah, I'll have that. Or you can actually extrude teeth and you can give me, better gingival margins and all sorts of things, or intrude teeth, whatever you need to do. I've had those patients I've treated, and generally they've done very well. Equally, I've had some patients saying, no, I can't handle that. It's too long, or, the cost involved, with all you guys involved here, or I'm not going to feel comfortable whilst you're moving an upper tooth in the aesthetic zone and there are spaces forming on the other side. How are you going to mask these spaces? How's it going to look? Because it's going to affect my mental health, and I've said, okay, look, in that case, this treatment isn't for you. You need to go to, the next level. And that will be, to talk to the implantologist or the restorative team and see what they could do. They may have to compromise here. The magic word in life here is compromise, right, Pav? There is no such thing as perfection. Equally, with all the implant guys I've ever worked with, none of them say an implant will last you for 100 years. Not because nobody can promise such a ridiculous statement like that. What they say is, well, you've lost the best set of teeth you ever had, your natural teeth. What I'm giving you is an artificial replacement. I will do my best in the world of today with the current technology and all the skills and knowledge I have. But I cannot make you a guarantee that this will, never have any issues and will go on for decades, and I just think, as you say, it's managing those expectations.
Yeah. So, Neil, next question for you. Again, and let's talk anterior aesthetic zone, okay? So quite often we get these cases where the patients had endodontics, and let's say they've got restorative breakdown. So the endo has worked. There's no periapical lesion around it, but the tooth is on its last legs just because it's fractured at gingival level. But let's say we can get some sort of temporary crown on there. And the cases that really worry me as an implant surgeon are those cases where you do CBCT and in the cross-section, the labial plate is really, really thin, because that's not alveolar bone, that's bundle bone. And when you take that tooth out, all of that bone's going to disappear. So the options then become: wait for it to disappear, you put in the implant, and you graft at the same time. Although I don't see the point of that. I'm of the mentality: if it's going to disappear, razor flap, get rid of it, and just augment it at the same time. Why are you wasting the patient's time? Okay. The other alternative is what we call socket shield technique, which I'm going to come on to on another podcast. But is it possible for these cases to extrude these teeth and bring the alveolar bone with it? What type of result would we expect if we did extrude?
Yeah, so you can extrude the teeth and you can generate vertical alveolar bone. Of course, alveolar bone is the best bone. It will beat any kind of synthetic material, hands down. So you can, if the tooth is already devitalized, you can extrude it orthodontically with a fixed appliance or whatever, and keep shaving the tooth down incisally until there's virtually nothing left, and the tooth is grade 3 mobile. Then you hand it over to your implant colleague, because they will just take out that tooth in 2 seconds, and they should be able to place a fixture in there. Or if they did need to graft, the graft will be a lot less than they were anticipating. So I've done that before as well.
Can you move bone peaks with that as well?
Can you move bone peaks with that?
With vertical, if you're extruding a tooth, if I'm assessing a case and it's like high smile line and the bone peak's not in the right position, I'm looking at it going, this is going to be a real nightmare. So with the extrusion, do the bone peaks extrude with it as well, or is that genetically predetermined?
No, I don't think you can change that. I don't think, but I think what you can do is basically as you extrude the tooth, you can generate vertical bone, and the soft tissue follows it as well. And that's as far as you can go, because you're moving a tooth in one dimension. So that's all you're doing. You're basically generating a better ridge. Anything else, it won't be possible in the scope of orthodontics.
Last question from my perspective now as well, because this is something that I see all of the time, where the 6 has been missing and the 7's tipped in behind it. What type of solutions do we have there?
So the upper sixes are missing, or the lower sixes.
Let's say so there's two more scenarios I want to cover with you, okay? I mean, they're both relating to the same one. Let's say the lower six is gone, okay? And the seven's tilted mesially, and or the upper six has over-erupted as well.
Yeah, then it's our good old friend in the world of orthodontics called skeletal anchorage. And that was one of the things you alluded to when we were texting each other 36 hours ago, because this podcast is off the cuff. It was not organized weeks ago. That's the truth. You place something on social media, and I have to give you credit that you're always working. You never stop, and that's the sign of a true professional. Basically, someone who's on their game. So I responded to that basically, and I told you what I think of. So if you've got these complicated malocclusions, the American Association of Orthodontists, which is the world's biggest healthcare group, even bigger than the medical side, plastic surgery, all of them, they have between 15 to 20,000 people every year attending their annual conference. They put out a survey some years ago, and they said in the last 25 years, what do you think the biggest breakthrough in orthodontics is? Is it digital? Is it aligners? Is it this? And the answer was skeletal anchorage, because what that's done is you can take a really complex malocclusion with all these problems you've just described, and you can simplify them for the next guy in the chain, which could be you, and you've just made that person's life easier. And by doing so, you may have improved the outcome for that patient. Yeah. If I make your life as easy as possible, then you can only be pleased with me, because if all your outcomes go as planned and the patient's over the moon, everything just is a tick box for you. Everything just clicks. Yeah. So in that case where you have a tilted six, what I've actually done is, if you've got a tilted seven rather, what I've actually done is I use mini implants or mini screws. And they've been around a long time, restoratively as a temporary prosthesis, right? To replace lateral incisors. You can put in these 11, 12 millimeter, mini screws or mini implants, and you can build up a peg lateral and composite, whilst the definitive dental implant is going to go in at some point. So we've been using these in orthodontics. The South Koreans came up with this over 25 years ago, and it's changed our lives. So what I've actually done is I've got two mini implants, and I've put them into the bone, and I will almost sort of angle the mini implants so they kind of mimic roots.
Yeah.
And I leave the head sticking out. I will then sandblast the top. I will then use a metal primer, and I will build up a molar crown. I've now got a molar crown in the region of the sixth space. And I'll put a bracket on that buccally pav. And once I grab, as I've got my arch wire going through there, I've grabbed the seven, and I'm now uprighting the seven, and I've got control of the tooth. Yeah, so I'm actually using skeletal anchorage to upright a second molar, so a first molar implant can go in. And if the upper seven has over-erupted, what I also then do, because you mentioned in the podcast, let's talk about ortho implants. So we can't exclude using implants or mini implants to aid orthodontic anchorage. So in the upper arch, I will put in two palatal mini implants. They're generally 9 millimeters long. It's just under 2 millimeters in width or diameter. And I'll put them in the anterior part of the palate from first premolar to first premolar. It's what we call the T-zone. That anterior part is the best bone because there are no major structures there. And I learned this, from my time in Germany. And then I'll make an appliance. We call it a mouse trap. It literally looks like a mousetrap appliance, and you're intruding the molars, bit by bit. You can either do unilateral or bilateral if you've got over-eruption on both sides. And I'll actually intrude the molars, again, using skeletal anchorage. And it works a treat. If you don't want to do that, you can put in some buccal mini screws and palatal ones either side, and you can intrude just using elastic chain. but the failure rate is about 30%, whereas when you put them in the anterior part of the palate, the failure rate's about 5%. So I prefer the anterior palate.
Yeah. So just to clarify, even with that lower 7 that you're uprating, is you're not actually bracketing and putting everything on the full arch. You're literally using skeletal anchorage and just moving the one tooth, right?
Yeah, you can do that. You can do a sectional fixed appliance. Why would you need the whole arch unless you plan to do other stuff? If you say, well, I'm gonna correct the rotated incisors, I've got the deep bite, I'm gonna tackle it all, let's put on a full lower arch, multi-band appliance, fair enough. But if everything else is reasonable, there's nothing to stop you from just, actually bracketing that 6, which is a fake dummy tooth anyway, and picking up your 7. And you've got the world's smallest fixed appliance there, doing a localized job, right? And it's almost invisible. Yeah, because not many people are going to see that. So, there's all sorts of tricks you can now do with skeletal anchorage, using sectional mechanics. You could even do it with aligners as well, and, mini screws. So, but the problem is, not many orthodontists in the UK know much about mini screws. They may have read about something in their training or seen something in a textbook, but hands-on practical experience, there aren't many places in the UK that I personally rate, because I think sometimes not all the answers lie in the UK. You've got to go overseas sometimes for your training. And you were doing that long before. When I met you all those years ago, you were going back and forth to the US at that point.
Mate, there was I can't remember what year it was. I think it was 2006. I did 10 trips to the US.
That's what I'm saying. Your passport has just got them rubber stamps in, yeah? But that's a sign of someone who's really dedicated. Basically, you are prepared to do what it takes to get that information because you want to learn it and you want to offer it to your patients so you can offer the best care possible. Now, not all clinicians are the same, Pav. Not all clinicians are. I also believe that. Not everyone is the same. I think those that have invested a lot of time, a lot of effort and a lot of finance into their training, I think they probably go a little bit further than someone who's done the bare minimum. I think that's a fair, obvious statement. And it might be reflected in the clinical outcomes as well. So I had to learn about skeletal anchorage from the South Koreans, and I spent time out there. And there were a couple of professors that mentored me because, they're the masters. And I spent time in Dusseldorf, Germany, learning about that from another professor who was head of department there. And after that, it just changed my game. When people were asking me to do the most, if you thought I was doing crazy things when you saw me present all those years ago, if I had time or if I could show you what I'm up to, people would, I think your TMJs would actually dislocate.
I think we need to arrange to go out for dinner, something like that, mate. Because I want to see the stuff that you're doing. Because I remember looking at it back then, just going, "Whoa, I didn't even know this stuff was possible." Then if you're telling me that that's old hat and you're doing even more
that's
crazy
old school, man. That's old school. That's like 1980s, rap music. Yeah, that's all. I've taken this thing to Star Trek.
Hey, nothing wrong with 80s rap music. Okay?
You're right, man.
It was from the 80s. Okay?
You're absolutely right. I remember those groups. Yeah, I used to listen to them as a kid and as a first year, university student. Yeah, we had all them groups. Ice Cube, Ice T, all of them.
Yeah, NWA. Yeah.
Yeah, we had some really good groups there. But yeah, so now I'm also doing skeletal anchorage in children. Yeah. And that might seem odd because if someone's got a narrow maxilla, the maxilla now has been linked, with the airway. And I knew this would happen because, if someone's got obstructive sleep apnea, what they're saying is if the mandible comes forwards, either surgically or it's assisted orthodontically, it can open up the airway, and sometimes, the snoring or their sleep quality can improve. Not guaranteed, but it can help. So what we're finding as well with the maxilla, sometimes if it can be expanded and it comes forwards, it can also assist. So with children, I'm doing something called MARPI, mini screw assisted rapid palatal expansion. I'm doing that in adults, but I'm doing it in children because what I want genuine bone-borne expansion. I want the maxilla to skeletally get wider. I don't want to just push teeth out out of the cortex. That is pointless for me. Because all you're doing is pushing teeth. I want, real expansion. So again, we will place these TADs, temporary anchorage devices, either two of them or four of them, and we'll expand. And again, you get aesthetically better results, but I also think functionally you get a better occlusion.
Interesting stuff, man.
But that's a talk for another time, because I've presented that in a number of countries in the last 6 months. I came up with something, novel and pioneering. I think it was the world's first. It was the world's first bone-borne appliance that was digitally designed. So me, a MaxVax surgeon, and a very passionate orthodontic technician in Greece who's very good on digital software. We came up with this idea and we tried it, and it worked. And then from there, I made a number of mistakes, but I documented the mistakes I made and how I overcame them. And then that led to people, inviting me to present my work, basically. So I had to present it to Turkey. I presented it to the Italian orthodontist, the Australian orthodontist. Next month, the American orthodontists have got me booked for a webinar. So that's the AAO Society, which I'm a member of. And they want to hear about it because it's quite fascinating. Yeah, I think orthodontists should not be afraid of actually using local anesthetic. I mean, for you, this is a joke. Yeah, when you hear that a dentist can't use local anesthetic, right? For you, it's an absolute joke. It's a travesty. It's got to be. But for me, I see orthodontists who have not actually picked up a syringe in a long, long time. They don't know how to give local anymore. Therefore, they are unable to place mini screws or mini implants. And I just think, okay, you're missing out here, guys, because if you can't solve this malocclusion, or you're compromising it and you're saying to other people, I can't do that, I'm leaving it. Well, you've got to kind of look at your own abilities here, Pav. How come others out there in certain parts of the world are doing it, but that individual can't?
Yeah, absolutely. Yeah.
So I think you get what you put in, basically. I think if you put the effort in, I think you learn more skills. So, yeah, I think skeletal anchorage is a big deal. I'm combining that with aligners now. I'm combining that with lingual appliances, and I seem to be getting cases where the first orthodontist or the second orthodontist or the third orthodontist has said, "I can't help you. We don't know what to do." So they'll come knocking on my door, and I'll say, "Okay, leave it with me. I need to just get my thinking hat on, and we're going to meet up again, and we're going to go through this in a bit more detail, and I'll present my treatment plan to them: treatment plan 1, treatment plan 2, treatment plan 3, and pros and cons, or risks and benefits, and let them ultimately decide, the patient, and then help them as best as I can. But for that, I charge a lot higher fees. One thing I've realized now as well, and I know this isn't related to implantology, it's related to your survival as a dentist, is try not to be the cheapest guy in the area. You're just asking for trouble, and you're just underselling and undervaluing yourself. Why is it that lawyers, an ordinary high street solicitor who has an LLB, which is less than our training, by the way, can command fees of £300 to £400 an hour? Why is it dentists have to, belittle their, worth after all that training, when we have much higher risks than solicitors? We've got indemnity cases, we've got regulators hanging over us. So, why should we work for, the lowest value of the pound? It doesn't make sense to me.
Shouldn't be market driven. It should be patient care driven and reflective of your skill set. And that's, and I've said this before. I get patients walking in through the door, waving a treatment plan at me, saying, "Can you price match this?" And I just say, "So I'm not even going to look at it." I said, even if my treatment plan's the same, I said, the only thing that I can guarantee you is I'm going to be more expensive than that piece of paper. I said, if you're looking for cheap, it's not me. There are plenty of other people there to help you. I said, if you want me to do it, you pay me my fees. But then
absolutely, and I respect that.
Like you, I get a lot of patients who come to me where they're just like, I've been told this isn't possible. I was like, it's possible. We'll do it.
I think as soon as you get a patient like that, okay, it's not about the clinical anymore. It just seems to have been, devalued and it looks like the relationship started by basically how quickly or how cheaply they can acquire your services. They're not looking at you, the team, the level of clinical care, the level of service. All of that is thrown out the window. And for me, that's very demotivating. It's very demoralizing.
So just to recap a little bit what we discussed, be careful of deep overbites, and unfortunately there's no shortcut to treating those. B, ortho-osteogenesis is absolutely phenomenal, but it's whether the patients are prepared to go through it. But what I would say is in certain cases, you're looking at a case going, this is impossible. Then you think to yourself, actually, can this be done orthodontically? And from an orthodontic point of view, it's actually relatively straightforward. And you're going to turn it from a nightmare case to an easy case.
Yeah, if I can do that, I've done my job.
Yeah. The next thing that we spoke about is uprighting teeth which have tipped using skeletal anchorage, which is easier and not easier for me because I don't do it, but for somebody like with the skill set of Sunil, it's easier and faster than having to bracket everything because then everything's on the move. So if there is a localized problem, your orthodontist hopefully can deal with it locally and quite swiftly. And what I would say is, I have had it before where I've warned patients of, and these are those borderline cases where I'm like, I might get away with it. I've warned patients about food packing. And there was even one case that springs to mind where the 7 needed a crown anyway. And I said, look, let's do the implant. We can do the crown on the 7 behind it and hopefully not have any issues. And it still bugged the patient because you just couldn't get the contours right because the teeth weren't at the correct angulation. So I think that's a really good way to summarize everything with regards to the orthodontics and implant interface. It's basically, the orthodontist can be your best friend and and take a nightmare case and make it actually really easy and straightforward for you. So, we need to be thinking about orthodontics when we're looking at these.
I completely agree. And I think, what it was, I mean, as I said in my text message to you the other day, we all need pals in this world. I'm no different. I've got, groups of people that I affiliate with. And it's having these people in your phone and just, good old WhatsApp and the speed of communication. That's exactly how we communicated in the last 36 hours. Even though I'm halfway around the world in the Middle East, I thought, you know what, I'm going to hook up with you. We're going to have a good, discussion. I'm going to learn from you as well. It's a win-win for me. I haven't seen you for ages as well, so it's always good to catch up with you and find out what you're up to.
I thought it was only a year ago since I saw you, but it's been about 3 or 4 years.
It was before the pandemic. It was before the pandemic, and then after that, the world just turned upside down, and all sorts of things happened. And it looks like you've gone, from strength to strength, which I'm very happy about. But as you say, it's great to have, these types of people. I mean, if there was one thing I could say on this podcast tonight, for the dentist listening, is please, please, please start making very valuable, important relationships that will serve you well in your clinical career. Make sure you got these people in your corner. It could be the endodontist, the periodontist, the prosthodontist, the implantologist, the orthodontist. Get your gang of people that you get on with really well, because that's important, because the relationship, it always comes down to that, as we've discussed this a number of times. And they're clinically very, very good. And these are the people also, they will not stop learning. People like yourself, basically, that everyone kind of needs that guy in their corner saying, well, what do we do? Well, let's ask Pav, what would he do? How can he help us? So these people, will always come to you for advice, and they become friends. Some of them become friends. So, because otherwise the loneliest feeling is handling something complex on your own in a 4-walled room, and those walls are closing in on you because you've got a tough patient who could turn on you, and you don't want that feeling of the stress, because we know stress is a killer. You don't want that. You want the load to be shared.
100%. Sunil, it's just if anybody wants to send patients to you for if they've got tips, molars, and whatnot, because your practice,
baby, I know where I am.
Yeah. So your practice name is Smile Lux, is that correct?
Yeah, correct. Yeah, we've been there 12 years. We started as a squat. We're a high-level private practice, and basically the practice is now fully digital. My team do the scanning. I do a lot of the treatment planning.
Yeah.
We do digital simulations for patients to see, what their predicted outcomes are like. Yeah. Even with the restorative dentist now, we will do digital simulations before I even put any brackets on those teeth or any aligner work starts. I'm saying, this is what I'm going to be sending you, and it's about 80% accurate. If you got this, are you happy? And once they email back to me saying, yeah, we're happy with this, and I'll give the patient 3D printed models. So in my clinic at the moment, because you haven't been, so you got to come over, and I will personally take you out for dinner, because there's a great Indian restaurant, right, that's just up the road from me, and I've been there several times, and it's one of the best Indian restaurants I've been to. So you have to come along as my guest, please.
100%, and it's something I've said to my wife as well. I said, look, when the little one, I said, if she needs orthodontics, I said, we're going to have to take her to Milton Keynes. I said,
I'm not retiring. I'm not retiring anytime soon. I've got another 15, 20 years left in me. I want to keep going because I love what I do. I get up at 6 o'clock in the morning and I do 12, 14-hour days all the time. And it's an obsession. So in my clinic at the moment, it's state of the art. It's 2 surgeries at the moment. It'll become a 3rd surgery. But I'm also building my own in-house laboratory. I want full control, or as much as I can get. So I want aligners to start on the same day. That means you see me in the morning. If you're happy, and I've consented you properly, and you're happy, we start at the end of the day. You'll be given your first 5 aligners. Nice. Yeah, that is service. No more hanging around for certain companies to deliver and all this stuff and having to deal with those lab fees. I want to produce aligners on the same day, retainers on the same day. We can, obviously do teeth whitening, mouth guards, whatever. And obviously I give my patients 3D printed models saying, this is the simulation I'm planning for you. Now take this to your general dentist or your prosthodontist or whoever. I will send them a letter. I'll tell them you got the 3D printed models to show them, and we'll work with you one step at a time. Yeah. And I just think that seems to be, the way forward.
Folks, I hope you can hear how passionate Sunil is with regards to orthodontics, and I hope you can see why he and I got on so well, because he's such a lovely guy. Sunil, your words are very, very kind. Thank you so much, and thank you for taking the time to speak to everybody this evening as well.
It's been a great pleasure that you asked me to be on this podcast. I'm very, very happy. As I say, I never say no to you. Anytime if I can, hook up with you and connect with you, it's always a laugh. I've always watched you. I've always loved watching you evolve, and that's you. You are someone who evolves over the time. You're never standing still. You're always moving forwards all the time. You will not quit. And I would say I would hate to compete with you in the world of dental implants. I wouldn't want to even go up against you. I would actually do something else, like orthodontics. I would just leave you to this, because I'm just thinking this guy basically, in another 5 years, he's left everyone else behind because he's found something else. But it's good. It's good. It means you love what you do.
Unlike yourself, just perpetually learning. You got to learn, and this is a conversation that you and I had just before we started recording. Is the more you learn, the more we realize the less that we actually know. For each one question that's answered, it opens up an avenue of 3 more questions. So all that happens is the older I get and the more that I study, I actually understand. The less I know, I just happen to get luckier in my outcomes. That's the way that I perceive it. So
listen, if you ever need me, you just call upon me whenever you need, because I'll put together some interesting cases of how they were then restored, and it will just open up more eyes and more possibilities. It's amazing how many dentists have said to me, I didn't know that was possible. I've been hearing that again and again. We didn't know you could do this. We didn't know you could do this. But you know what it is? It's the creativity.
Well, I'll tell you what. Let's get you a module on my on my Academy of Implant Excellence course, which is coming up. I think that might be actually a good.
That'd be great, because I haven't seen that before on any other implant course, so it would be novel.
Yeah.
It would be novel.
Okay,
you know, as long as you buy me dinner,
don't worry, mate.
I want a nice chicken curry, right?
Yeah. I know some awesome places around here. Honestly, you come. I'm only in Beaconsfield, mate. Half an hour, like 45 minutes to an hour away from you. There's some awesome places around here. So
get me some chicken curry and some naan bread, man. I will do anything. All right, that's it. You know, but not for anybody else. Only for you, because as I said, I've got a lot of love and respect for what you've been doing all these years.
Mutual, thank you so much.
And keep pushing, man. Keep pushing the way.
I will do. So just to say goodbye to everybody, thank you for those listening. The last message going out there is, please have a look at the Academy of Implant Excellence course. It's very, very close to launching now, academyofimplantexcellence.com. I have had a number of people reach out to me with regards to hands-on mentoring, which is possible as well. So feel free to message me about that. There's a number of ways that we can do it. You can bring your patients to my clinic. That way, the patients pay me directly, and there's no fee for you to pay. Either myself or one of my mentor friends can come to your clinic, and we can discuss that if that's easier for you. But I'm also excited because I'm in talks with another colleague abroad, where we may be able to go for a week and just place 20 implants. So for those who want like a really fast start, and I can't tell you exactly where yet, but you know what? I'd love to go myself. There is a scope of doing that. So what I would say is, if we can get 7 to 10 people per cohort ready to go, I can very, very easily make that happen. And what I would say to you is, this place is going to be phenomenal. You're going to have the time of your life. So there are a number of options available, not only for me to teach you my way of doing implants and everything that I know theoretically, but also to accelerate your career and get you placing implants and get your or increase your skills, get you doing more complex stuff. There are definitely ways that we can help you. Thank you very much, everybody, for listening.